This time we are going to talk about valves part 2. So in this part 2, we are going to talk about specific disease conditions and also some algorithms like cardiac arrest, post-cardiac care, bradycardia, tachycardia, so on and so forth. First, bradycardia. The symptomatic bradycardia is very important, especially in adolescent with um, involved in lots of sports related activities. They tend to run low heart rate. So they are asymptomatic bradycardia. So when you have bradycardia, make sure the patient has symptomatic or symptoms because of bradycardia, like low blood pressure, pulmonary edema and congestion, abnormal rhythm, chest discomfort, shortness of breath, lightheadedness, confusion, and syncope. There are 5 conditions that can cause bradycardia in children and also in adults. Sinus bradycardia, which is the most common, first degree AV block, type 1 secondary AV block, type 2 and third degree AV block. The first degree AV block, the PR interval is just prolonged, more than 0.20 seconds. Type 1, in this PR interval, progressively increase till the QRS complex is dropped. In type 2, the PR interval is same length with intermittently dropping QRS complex. There is no progressive increase in PR interval lengthening and dropping QRS complex. The third degree, the PR interval and QRS complex, they are not coordinated. They merge to the different tune. So when you see a patient with bradycardia, you need to check, number one, heart rate, that confirm abnormally low heart rate or a significant rate drop from the previous normal. Then immediately go through A, B, C, D, E. Number one, airway, breathing check, oxygen sat, the administered oxygen as needed, and check the blood pressure and the pulse until the EKG. And if there is hemodynamic instability, get an IV. If you can't, get the IO. Disability, check neurostatus and check for signs of trauma, burns, fractures, etc. The next one is check the mental status. Are these symptoms caused by bradycardia? Do not delay CPR. Epinephrine 0.01 milligram per kilo, either via IO or IV, can be given every 3 to 5 minutes. The practice is every 3 minutes. I do not know why the PALS and ACLS says 3 to 5 minutes. We typically do every 3 minutes. Atropine, the dose is 0.02 milligram per kilo. It can be repeated once. If the drugs are unsuccessful in reverting or the patient has third degree heart block, consider transthoracic transvenous pacing. Transthoracic is easier since if you have AED, you need to crank up the amplitude that captures the heartbeat. So you can stabilize and transfer them to cardiac or intensive care unit. The primary goal of symptomatic bradycardia is to make sure the heart is adequately pumping blood to the body. That means ensuring adequate perfusion. The treatment is not necessarily aimed at increasing heart rate. Treatment should continue until the symptoms and signs resolve. That is a very important point. If the person stops having pulse, move to the cardiac arrest protocol, which we are going to discuss later on in the seminar. Always consider the reversible causes of bradycardia in pediatrics and treat if possible. Most of the cardiac arrest in children, respiratory, and also because of some reversible causes like hypoxia, hypovolemia, tension pneumothorax, so on and so forth. Atropine doses less than 0.1 milligram may worsen bradycardia. That is the lowest dose you use, which we are going to discuss. So how to approach a patient? Number one, let's talk about the doses and details of epinephrine. The dose of epinephrine is 0.01 milligram per kilogram. Repeat, I would say every 3 minutes. Attempt IV, do not spend too much time on it. If you cannot get it in 10-15 seconds, go for IO. When you do an IO, intraosseous line, make sure you use the electronic, the drill method. That is much more successful than the manual one because it tends to slip and as a result it is wrongly placed. If it is wrongly placed and the medication you give does not get into the bloodstream, as a result have a bad outcome. Atropine, the dose is 0.02 milligram per kilo. It can be repeated once. The minimum dose is zero point 0.1 milligram. The maximum dose is zero point 0.5 milligram. If you give anything below zero point 0.1 milligram, it can cause paradoxical bradycardia. Identify and treat the underlying cause. Maintain pattern airway and assist breathing if necessary. If you are listen to the previous seminars, in all unconscious or semi-conscious patients will have airway obstruction because everything falls back, tongue falls back, the muscles are relaxed. As a result, they do have airway compromise that need to be ascertained. If hypoxemic, administer oxygen. Use cardiac monitor to identify rhythm, monitor blood pressure and pulse oximetry, and immediately get an access and get a 12-lead EKG. If the bradyarrhythmia is causing, that means symptomatic hypertension, mental status changes, and then start CPR, especially if the heart rate is still less than 60. So poor perfusion despite oxygenation and ventilation. And most of the time, just improving perfusion and oxygenation reverts back. If it persists, then start epinephrine, give atropine, and consider transthoracic or transvenous pacing. Transthoracic, as I said, it is easier when you have the pads. If the patient develops pulseless arrest, then you need to move to pediatric cardiac arrest algorithm, which we are going to talk. Next is tachycardia. What is tachycardia? Tachycardia is defined as a heart rate greater than what is considered normal for a child's age. When the heart beats too quickly, there is a shortened relaxation phase. The ventricles are unable to fill completely. Coronary arteries receive less blood, so supply to the heart is decreased. There are five reasons we encounter in the pals. One is sinus tachycardia, the normal rhythm and fast rate. Likely not dangerous, but not necessarily. It may be a precursor for cardiac arrest. So you have to be very careful. If you do not tackle sinus tachycardia, especially in shocky state, they will go into cardiac arrest. But vast majority of them occurs during stress and fever. The second most common we encountered is supraventricular tachycardia. Rhythm starts above the ventricle. That's the reason the name goes supraventricular. Atrial fibrillation is not that common in children except in the post-op patients with dilated atria. Causes irregular heart rhythm. Atrial flutter, again uncommon, but causes typical sawtooth pattern in EKG. Ventricular tachycardia, rhythm starts in the ventricle. It is not uncommon, especially when the patient is sick. So you need to identify early and tackle them right away. What are the signs and symptoms of tachycardia? They can present as respiratory distress or failure, poor tissue perfusion, meaning low urine output, altered mental status, pulmonary edema and congestion, and weak rapid pulse. So when when you have a tachycardia, immediately look at the QRS complex, whether it is less than 0.09 second or the QRS complex is more than 0.09 second. In order to read how to read the EKG and how to calculate QRS complex, there is a chapter in we discussed in PALS 1 and also ACLS 1. Okay, narrow QRS complex is less than 0.09 second, which is seen in atrial fibrillation, atrial flutter, sinus tachycardia, and supraventricular tachycardia. Wide QRS complex you see in ventricular tachycardia, and unusual SVT. There are certain SVT will have prolonged QRS complex. As you mentioned earlier, atrial fibrillation will have a typical sawtooth pattern. It's caused by an abnormal pathway that causes atria to beat very quickly and ineffectively. Atrial contractions may exceed 300 beats per minute. The pulse providers will have to distinguish between sinus tachycardia and supraventricular tachycardia. SVT is more commonly caused by accessory pathway reentry, AV node reentry, and ectopic atrial focus. In sinus tachycardia in infants, the heart rate usually less than 220 beats per minute. On the contrary, in SVT, the infant will have a heart rate more than 220 beats. Children less than 180 beats, sinus tachycardia, and supraventricular SVT, it's more than 180 beats. Sinus tachy is slow onset, SVT is abrupt onset. Sinus tachy associated with fever and hypovolemia, SVT, if it is longer duration, associated with pulmonary edema. Sinus tachy varies with stimulation. SVT is typically is constant fast rate. In sinus tachy, you will see P waves. In the SVT, the absent P waves or buried P waves. Next is prolonged QRS duration. If you look at the QRS duration, would be more than 0.09 seconds. VTAC is uncommon in children but can be rapidly fatal. The QRS duration is more than 0.09 seconds. The ventricular tachy can be polymorphic, usually ominous signs. If it's a monomorphic, usually it's not that bad. If it is polymorphic, that means it may get degenerated into ventricular fibrillation or torsades. Be careful. Torsades and unusual SVT with wide complexes due to aberrant conduction. Any of these rhythms can devolve into ventricular fibrillation. So when you see polymorphic VTAC, torsades, and unusual SVT, act promptly. Otherwise, it will degenerate or devolve into ventricular fibrillation. So how do you approach these patients? Number one, maintain pattern airway. Assist breathe if necessary. If hypoxemic, administer oxygen. In fact, most of the patients will be getting oxygen by this time. Cardiac monitor to identify rhythm, monitor blood pressure and pulse oximetry, and the IV or IO access, and get 12 lead EKG. The doses and details in synchronized cardioversion begin with 0.5 to 1 joules per kilogram. If not effective, go up to 2 joules per kilogram. Some patients may need sedation. Most of the patients do not need because they are so sick. The adenosine dose is first dose 0.1 milligram per kilogram, the max of 6 milligram. If it doesn't respond, go to second dose, basically double the dose, 0.2 milligram per kilogram to the max of 12 milligram. Once it is converted, and give amiodarone 5 milligram per kilo, 20 to 60 minutes, or if the patient doesn't respond, go ahead and do amiodarone 5 milligram per kilogram run over 20 to 60 minutes. Procainamide 15 per kilo over 30 to 60 minutes. And once you have a tachycardia, look at QRS duration, narrow or wide. If it is narrow, evaluate rhythm with 12 lead EKG. And if you think it is probable sinus tachycardia, check the history whether it is consistent, whether there is a P waves in front of the QRS complex. Variable RR wave usually seen in sinus tachycardia. On the contrary, SVT, the RR interval is constant. In infants, the rate would be less than 220. In children, it is less than 180. If you think it is SVT, you will have a telltale signs. Abrupt onset. There are no P waves. Heart rate is not variable, constant. The infant's heart rate is usually more than 200, children more than 180. If the QRS is prolonged, That means it is ventricular tachycardia or rubber and SVT or any of those. Assess for any compromise like hypotension, mental status, and signs of shock. If it is there, go for synchronized cardioversion right away. If there is none, if there is no compromise, consider adenosine, basically converting rhythm at that point. So once it is converted, and of course, give you amiodarone or procainamide and consult specialists. In SVT, once it is stable, attempt vagal maneuver. So only in a stable patients you can do a vagal maneuver and adenosine. If the patient is unstable, go for synchronized cardioversion. It's a very important point to remember. Third category is shock. What is shock? Shock is defined as a condition in which peripheral tissues and end organs do not receive adequate oxygen and nutrients. Initially, body will try to compensate, most commonly through increased heart rate. Because cardiac output is equal to heart rate and stroke volume. The blood flow will be shunted from less vital organs such as skin to more vital organs such as brain and kidneys. There are 4 types of shock in general. In hypovolemic, low blood volume, often due to hemorrhage or fluid shifting out of vasculature. Distributive, blood vessel dilation that's seen in septic shock. Cardiogenic, heart is not pumping adequately, an obstructive physical block of the blood flow, which we are going to explain a little bit in detail in subsequent slides. Hypovolemic shock. It is the most common type of shock. It results from insufficient blood in the cardiovascular system. Most of the time it happens because of diarrhea, vomiting. In the United States, most common cause of hypovolemic shock is hemorrhagic. The preload is decreased, contractility is normal or increased. Afterload is increased because the vessels have constricted, is a normal adaptive response to the hypovolemic shock. What are the signs of hypovolemic shock? They will have tachypnea, tachycardia, adequate low blood pressure, narrow pulse pressure, slow capillary refill, weak peripheral pulses, normal central pulses. There is a discordance between periphery and central, and decreased urine output. Distributive shock. Majority of the blood is inappropriately distributed in the vasculature, hence the name distributive shock. The vasculature has relaxed and dilated to the point of inadequacy. In distributive shock, the blood is not being maintained in the required and needed blood vessels. The distributive shock is most commonly seen in patients with sepsis, anaphylaxis, or neurological issue like spinal cord injury. In distributive shock, the preload, contractility, and afterload vary depending on the etiology. Let's look at this. Look at this one. In septic shock, anaphylactic shock, and neurogenic shock, all can cause distributive shock. The preload is decreased in all 3. When you look at the contractility, in septic shock, contractility may be normal or decreased based on what stage of the septic shock the patient is in. Anaphylactic shock, again, contractility varies. Neurogenic shock, the contractility is unaffected. But the afterload, again, varies in septic shock. In warm shock, the afterload is low. In cold shock, the afterload will be high because of vasoconstriction. Anaphylactic shock, afterload is low in the left ventricle and high in the right ventricle. Neurogenic shock, afterload is decreased across the board. So what are the common signs and symptoms? Tachypnea, tachycardia, low to normal blood pressure, decreased urine output, and decreased level of consciousness. Third category of shock is cardiogenic shock. In cardiogenic shock, it's caused by inadequate contractility of the heart. One of the key differences between hypovolemic and cardiogenic shock is the work of breathing. In hypovolemic shock, there will be tachypnea. In cardiogenic shock, there is increased work of breathing. The reason being, in cardiogenic shock, the lungs are loaded with fluid. So these patients will have grunts, nasal flaring, and use of accessory thorax muscles. Pulses are often weak, kept briefly slow, the extremities are cool and cyanotic, and there may be a decrease in the level of consciousness. Obstructive shock, similar to cardiogenic shock, impaired heart function is the primary abnormality. The heart is prevented from contracting appropriately. The common causes of obstructive shock are cardiac tamponade, tension pneumothorax, congenital heart malformations, and pulmonary embolism. In obstructive and cardiogenic shock, distinguished by contractility of the heart. Contractility is normal in obstructive. In cardiogenic shock, the pumping function is affected. Cardiac tamponade, you will have a muffled heart sounds, pulsus paradoxus, meaning there is a drop in blood pressure during inspiration. Tension pneumothorax, you will have tracheal deviation, absent breath sounds on the affected side of the chest. Pulmonary embolism, the patients are cyanotic or hypotensive. Chest pain, and has respiratory distress without lung pathology or airway obstruction. The risk factors for pulmonary embolisms are obesity, hormone use, family history of abnormal clotting, and coagulation factor abnormalities. We see more and more of pulmonary embolism, and of course, you see tamponade tension pneumothorax in patients who had automobile accidents. So, how to respond to a shock? The goals of shock is one, to get oxygen to the tissues and to organs. Enough oxygen in the blood, getting blood to the tissues, keeping the blood within the vasculature. These are the three main goals of the shock. The correct blood pressure and heart rate varies for the age. So when you are dealing with children, make sure it's appropriate for that particular age. Restore normal pulses, capillary refill, and mental status, along with urine output should be more than 1 ml per kg per hour. In hypovolemic shock, the primary means of responding to hypovolemic shock is provide additional volume. So what kind of fluid you use? Usually isotonic crystalloid fluids like normal saline and lactate or ringers. The current recommendation is 20 per kilo bolus over 5 to 10 minutes and repeat as needed. Oftentimes, you push the fluids fast. When you are dealing with the hemorrhagic shock, administer 3 ml of fluid for every 1 ml of blood lost. That is 3-to-1 ratio. If fluid boluses do not improve the signs of hypovolemic hemorrhagic shock, consider administering PRBC transmission without a delay. How to deal with distributive shock? Initial management is to increase intravascular volume. If you look at the distributive shock, all of them will have low preload. The dose you give it is 20 per kilo of fluid over 5 to 10 minutes and repeat as needed. Then therapy is tailored to the cause of the distributive shock. Third is septic shock. Again, aggressive fluid management is usually necessary, and broad spectrum antibiotics needs to be given early in shock. The stress dose of hydrocortisone, especially in those patients who are not responding to pressures. What are the pressures you use? This is according to the PALS. If the patient is normotensive, one can use dopamine. If the patient is in warm shock, norepinephrine. If the patient is in cold shock, epinephrine. Please, I would refer you to check the septic shock 2021 guidelines. Already did a seminar on septic shock, and also general concept. It talks more about septic shock because the people have moved away from dopamine, even though PAL says dopamine in 2020-25 guidelines, they might change in coming year. Just keep up to date because the Society of Critical Care Medicine already changed their guidelines. The first go-to is norepinephrine and add epinephrine and vasopressin. Please listen to those seminars. The PRBC transfusion bring hemoglobin above about 10 gram per deciliter, which decrease oxygen carrying capacity. I wanted to say again, this is PALS guidelines, and most of the guidelines they limit the transfusion up to 7 gram per deciliter. Okay, the next one is anaphylactic shock. IM epinephrine is the first and the most important treatment for anaphylaxis. In severe cases, second dose may be needed or IV administration may be needed. Crystalline fluids can be administered judiciously. Antihistamines and corticosteroids can also blunt the anaphylactic response. For breathing challenges, one may have to use albuterol nab or salbutamol nebulization if the patient has bronchospasm. Neurogenic shock, injury to the autonomic pathways in the spinal cord results in decrease in systemic vascular resistance and hypertension. And inappropriately, this is a very important hallmark, inappropriately low pulse and bradycardia is a clinical sign of neurogenic shock. Treatment, fluid bolus, 20 per kilo over 5 to 10 minutes. If hypotension persists, and use pressors. Neurogenic shock, the pressors can be norepinephrine and epinephrine. This resuscitation should be done in conjunction with a broader neurological evaluation and treatment plan. In cardiogenic shock, how to treat? The primary goal of therapy is to restore cardiac contractility. Fluid resuscitation, not a primary intervention in cardiogenic shock. Oftentimes, their preload is pretty high. In normotensive patients, one can use vasodilators and diuretics. Contractility is supported by inotropes. Milinone is often used to decrease peripheral vascular resistance. When additional volume is needed, fluid can be administered slowly and cautiously. Typically, we give 5 per kilo and check the response. If the response is good, you can gingerly give fluid boluses. If the patient is worsened, and stop. Obstructive shock. The cause of obstructive shock requires rapid and definite care. For example, cardiac tamponade requires pericardial drainage right away. Tension pneumothorax needs needle decompression, subsequently placement of chest tube. And other vascular abnormalities need to be dealt by pediatric heart surgeons. There is a left-sided obstructive lesions, right-sided obstructive lesions. Most of them, they need PGE1 immediately and followed by some shunt placement. Finally, pulmonary embolism. Most of the time supportive treatment, but sometimes we may have to do fibrinolytic and anticoagulant agents by the trained personnel. Next is cardiac arrest. Cardiac arrest can often be avoided if respiratory failure and shock is successfully managed. So the early identification and treatment is very necessary. Vast majority of the pediatric cardiac arrest can be averted. Number one, if the parents bring the patients early enough. Number two, at the emergency room or urgent care center or in primary care office, identify early and act immediately, then the patients will not move into cardiac arrest. Less than 10% of the time, cardiac arrest is a consequence of ventricular arrhythmia that also you need to be aware of. It may be possible to identify a reversible cause of cardiac arrest and treat it quickly, the most common being hypoxemia and hypovolemia. There are 6 H's and 6 T's. Hypovolemia, hypoxia, acidosis, increased hydrogen ion concentration, hypo or hyperkalemia, hypoglycemia, and hypothermia. The T side, tension pneumothorax, tamponade, toxins, thrombosis could be coronary, pulmonary, or unrecognized trauma. The important thing is recognizing arrest rhythms. I want to show 2 sets. The arrest rhythm can be asystole or pulseless electrical activity. These 2 rhythms are considered non-shockable rhythms. Most of the time, they occur because of some reversible causes. The second group is ventricular fibrillation and pulseless ventricular tachycardia. These rhythms, even though they are ominous, good news is that can be shockable and revert back to the normal rhythm. When you see the arrest rhythms and look for following things like ABCD run through real fast with the airways open. The patient is breathing effectively or slow breathing. The circulation is good. Bradycardia, hypotension, look at the pulse. Weak central, is there any discoordination between peripheral and central pulses? And skin changes like mottling, cyanosis, and coolness. And disability, decreased level of consciousness. And look for bleeding, hypothermia, and trauma needs to be surveyed real quick. If you're experienced, all can be done real quickly when you are assessing the arrest rhythms. Let's talk about unshockable rhythms, which are pulseless electrical activity and asystole. They are omnious rhythms and they are unshockable. In asystole, you see a flat line. There is no perceptible cardiac electrical activity. Make sure it is not technical error. The wires are not connected. That can give you asystole too. The asystole often preceded by an agonal rhythm. What is agonal rhythm? You can have a beat, then there is nothing, then another beat, then another, nothing, before it becomes a flat line. The second category is pulseless electrical activity. It can have any number of EKG waveforms, including sinus rhythm, except PEA cannot have ventricular fibrillation, VTAC, or asystole. So they are different by valves and the ACLS. The second group is shockable rhythms. Those are all ventricular fibrillation and pulseless VTAC. They're again life-threatening rhythms, but they are shockable. Ventricular fibrillation, there is a rapid curing of the ventricles instead of forceful contractions. And pulseless VTAC occurs when the rapidly contracting ventricles are not pumping blood sufficiently to create a palpable pulse. In both ventricular fibrillation and pulseless ventricular tachycardia, victims are not receiving adequate perfusion. That is the important thing. So by shocking, you revert the rhythm back to the sinus. So how do you approach these patients? Number one, activate emergency response, as we discussed in BLS. Start CPR, give oxygen, and attach monitor and defibrillator. The AEDs detect whether the rhythm is shockable or not, but the AED cannot check the pulse. So if you see the tachycardia, ventricular tachycardia, whether the patient has pulse or not, it is the responder needs to assess. So the BLS is very important. If the rhythm is shockable, that means ventricular fibrillation or pulseless ventricular tachycardia, administer shock. Immediately follow the shock, do the CPR for 2 minutes, get an access. So when you're switching from one to another, minimize the interruption. The interruption should not be more than 10 seconds. If the rhythm is not shockable, meaning pulseless electrical activity or asystole, start CPR, get an access, could be IV or IO, and start giving epinephrine every 3 minutes and consider advanced airway. If there is no shockable rhythm, continue CPR for another 2 minutes. Every 2 minutes, check for rhythm. If there is a shockable rhythm, administer shock and followed by CPR for 2 minutes and another shock, administer, then continue every 2 minutes and give amiodarone, lidocaine, and treat the reversible causes. If the rhythm is not shockable, go to pulseless electrical activity algorithm and organized rhythm, check pulse, especially when you have pulseless electrical activity, usually caused by reversible causes. You identify and treat, then you can have return of spontaneous circulation, otherwise called ROSC. Once you reach the return of spontaneous circulation, move on to the post-cardiac arrest care, which we are going to discuss. So when you do a CPR, give a compression at the rate of 100 to 120 compressions per minute. The compression depth would be 1/3 of diameter of the chest, which is 4 centimeter in infants and 5 centimeter in children. Minimize interruptions. Interruptions cannot exceed more than 10 seconds. Do not overventilate. Rotate compressors every 2 minutes. That means after every 5 cycles, then you need to have a different chest compressor. If there is no advanced airway, 30 to 2. That means 30 compressions and 2 breaths. If there are 2 providers, or you do 15 compressions and 2 breaths. If you have an advanced airway, you need to breathe 10 to 15 breaths per minute. You can provide 10 to 15 breaths per minute for one provider, 20 to 30 breaths per minute for 2 providers when continuing chest compression. So in the prior one, you do compressions, give breaths. Here, both happen simultaneously. One person or one group of persons do chest compression separately, and if it is an already advanced airway, the airway person not only maintain the airway and hold the tube or secure the tube and give a breath at that rate. When there is a shockable rhythm, the first shock should be delivered at 2 joules per kilo. Usually, if you have an AED, it automatically delivers. You need to just push the button. The second shock, you should double it, 4 joules per kilo. Subsequently, you can further escalate the dose more than 4 joules per kilo. It can go all the way up to 10 joules per kilo or adult dose. What is return of spontaneous circulations? Return of pulse and the blood pressure. Spontaneous arterial pressure waves with intra-arterial monitoring. Advanced airway. What is advanced airway? Supraglottic advanced airway or endotracheal tube intubation. ET intubation is the most secured form of advanced airway but needs technical expertise. When you do ET intubations, make sure you confirm not only by visualization and air entry on both sides, and also by capnography. Once advanced airway in place, one breath every 2 to 3 seconds. That translates into 20 to 30 breaths per minute. This is for pediatrics. When you use drug therapy, the dose of epinephrine is 0.01 milligram per kilo. Repeat every 3 minutes. The dose is same for IV and IVO. For endotracheal tube, 0.1 milligram per kilo. Nowadays, we rarely use endotracheal because IO access, intraosseous access happens right away in the field. Amiodarone, the dose is 5 milligram per kilogram. Bolus during cardiac arrest can be repeated up to 2 times for refractory ventricular fibrillation and pulseless ventricular tachycardia. So amiodarone needs to be given bolus during cardiac arrest. In a non-cardiac arrest situation, it can be run over 5 to 10 minutes or 10 to 20 minutes. So what are the reversible causes, which we already mentioned? 6 H's and 6 T's. Hypovolemia, hypoxia, increased hydrogen ion concentration, otherwise called acidosis, hypothermia, hypo or hyperkalemia, hypoglycemia, cardiac tamponade, toxins, tension pneumothorax, pulmonary thrombosis, coronary thrombosis, and trauma. Next is post-resuscitation care. The initial resuscitation saves the patient from death. The post-resuscitation improves outcome. Those are 2 different goals. So what are the things you address once you have rhythm is established, return of spontaneous circulation is established? Then don't give away, because the outcome depends on the post-cardiac care, post-cardiac arrest care. Chest X-ray to verify ET tube placement if it is already done. Check the blood gas to make sure the oxide base is optimal. Pulse ox, heart rate and rhythm, enteral CO2 if the patient is intubated. Maintain oxygenation 94 to 99. Avoid hyperoxemia. Maintain adequate ventilation. The PCOT, like to keep it between 35 to 45. Don't be hypercarbic or hypocapnic. Intubate if the oxygen and other interventions do not achieve adequate oxygenation. Maintain pattern airway in a child with a decreased level of consciousness, especially when the GCS is less than 8. Go ahead and intubate and secure the airway. If the ventilation is not possible by non-invasive means, go ahead and do intubation. And sometimes the patient need analgesic and anxiety, especially following trauma they may need. Cardiovascular. Again, blood gas and make sure acid-base balance is optimal. Hemoglobin hematocrit needs to be kept optimal by transfusion or support. Check the heart rate and rhythm. Keep the blood pressure normal. If you have central venous line, central venous pressure, urine output, all these patients need to have Foley catheter in place to measure the accurate urine output. Chest X-ray, 12 lead EKG for rhythm as well as cardiac size. Consider echocardiography. In most circumstances, we routinely do echocardiography to find out the contractility of the heart. Maintain appropriate intravascular volume, treat hypotension, pulse ox, and maintain adequate oxygenation, typically 94 to 99, and correct metabolic abnormalities. The renal system maintain the urine output more than 1 ml per kg per hour in infants and small children, larger children more than 30 ml per an hour. When you see exceedingly high urine output, and that might indicate neurological renal problem. The so-called diabetes insipidus typically happens few hours after the cardiac arrest. It doesn't happen immediately the aftermath of the cardiac arrest. Check the routine blood chemistries, blood gas, urine analysis, maintain cardiac output and renal perfusion. They consider the effect of the medication on renal tissue is very important. Avoid any kind of nephrotoxic medications. If it was already given, just to stop it. Sometimes, if the cardiac arrest or cardiopulmonary arrest happens because toxin and immediate hemodialysis can save the patient. Neurologically, elevate the head end of the bed in all those patients. When you do that one, make sure, yes, especially if you suspect spinal cord injury, and keep the neck collar in place. Avoid hypothermia across the board. In neonates, hypothermia definitely helps to preserve the brain function. So follow neonatal protocols. Check blood glucose and address right away. If the patient has seizures or altered mental status, I will give seizure medications, prophylactically start anti-seizure medications. Blood pressure needs to be maintained and maintain cardiac output and cerebral perfusion. Normal ventilations, keep the PCO2 between 35 to 40 or 35 to 45. Check neurological exams every hour. Consider CT and EEG, especially if the patient has an altered mental status. And look for dilated pupils, hypertension, bradycardia, respiratory irregularities, or apnea. GI, nasogastric and orogastric tube for patency and residuals. Perform abdominal examination. Consider ultrasound CT as appropriate. Routine blood chemistry, blood gases, and be vigilant for bleeding into the bowel, especially after hemorrhagic shock. Hematologically, blood count and coagulation panel, most of the time we need in all shock patients. Transfuse as needed to correct thrombocytopenia, FFP, and other clotting factors, and consider calcium chloride or gluconate if massive transfusion is required, and correct metabolic abnormalities. So how to approach? Optimize the ventilation, titrate FiO2 to keep the saturation 94 to 99. Consider advanced airway if it was not done yet. Assess for threat or persistent shock. Give a fluid bolus with isotonic crystalloids and use pressors to improve the blood pressure and the perfusion. And look for the reversible causes, the 6 H's and 6 T's. If the patient is hypotensive, start epinephrine, dopamine, norepinephrine. If it's normotensive, dobutamine, dopamine, epinephrine, and milrinone. It's not in the order based on the type of the shock one should use. Monitor and treat agitation and seizures and hypoglycemia need to be checked and treated, and blood gas and electrolytes and calcium needs to be kept optimal. If the patient remains comatose after resuscitation, consider therapeutic hypothermia. What is 32 to 34 centigrade? In pediatrics and adults, 24. I think neonates, they'll go on for 72 hours. At this point, consider specialist consultation or transport to the tertiary care center. These are the important points, the PALS essentials. Number one, prevention does not require advanced skills. So early intervention needs early identification, especially in pediatrics. If you identify early and act early, you can prevent cardiac arrest and save the child. Mentally prepare for treating the child or infant as you approach the scene. Assess appearance, workup breathing, and skin color. If the child's or infant general appearance provides important clue, that is my feeling. Usually they are lethargic, they are drowsy, that means they are real sick. Most of the kids are alert and interactive. In sick infants or sick children, you don't see that alert and interactiveness. Head bobbing is a sign of respiratory distress. When you have head bobbing with severe, even though they are alert and looking around, they can be potentially going to respiratory arrest. So always admit those patients. Normal pulse oximetry reading does not exclude respiratory distress. If the patient is hypoxemic, they can be irritable. So check the pulse ox, check the heart rate and other vital signs. Slowing of respiratory rate, especially when the patient in distress, that means it is going to have a respiratory arrest. Bradycardia in children most often due to hypoxia. Especially when you have a tachycardia and the heart rate falls in front, that means he's going to cardiac arrest. Act immediately. During that time, if you hypovolemia, most of the time it's hypovolemia and hypoxia, just if you address those two, you can avoid cardiac arrest. Sudden infant death syndrome is a leading cause of death for infants for 1 month to 1 year. Just keep that in mind. The unexpected death of a child is stressful to the rescuer as well as to the provider and to the parents too. If foreign body is suspected, look inside the mouth and the airway before suctioning. Always look. The blind scooping, which we used to do, is no longer the practice. It's inadvertently, it can push the foreign body inside the airway. It's better to learn how to use nasopharyngeal airways. Lots of times, nasopharyngeal airway will help you to keep the oxygenation and ventilations, especially in the patient has seizures or other causes for altered mental status. As I mentioned earlier, do not blindly sweep the airway because it can push the foreign body further down. So when you use the mask, don't just slam and push because that can obstruct the airway. Pull the jaw up to the mask rather than pushing the mask on the face. It's a very important point. Another important point is deliver breath slowly over 1 second. Making faster or wrongly can cause gastric distension. So open the airway, nicely fit mask, and give breath over 1 second. And watch the chest rise. It's a very important point. This concludes the seminar on pediatric life support, part 2.